What's up, everyone? Floating Vent Guy is back for another edition of the Peak Inspiratory Podcast. I said that I'd be doing peak inspiratory pressure this week, but unfortunately, my kids gave me whatever emotive GI illness that they had over the past week. So, spent a few days in bed with a fever and sort of not feeling so hot, but getting better. But wanted to hop on and talk about, I think, spontaneous breathing trials, only because it's come up in conversation a few different times in the past couple weeks over like how much pressure should it be? Is it T-piece? What is an SBT? And sort of the implications of maybe extubating aggressively and having reintubations or leaving people intubated and then having longer mechanical ventilator lengths of stay. So I don't have much time because unfortunately I was tasked with doing a bunch of home stuff by my wife, but I figured I'd do, a couple minutes on this and get some thoughts and do peak pressure another time when I have some time to sort of prepare. So I think the first thing is that, what is an SBT? And I think the first myth we have to sort of dispel is that we don't wean patients off the ventilator anymore. This has come up multiple times on multiple platforms, actually. But this has come up multiple times on multiple platforms about what exactly is an SBT, what's weaning, do we wean, etc. So remember, way back when, we used to sort of wean patients over days to weeks. At first, the way they figured out how someone may or may not be a candidate for weaning is their RSBI score less than 105 or something. So that was made by Tobin and Yang in like the 90s. Remember, the RSBI score was done on T-piece. So not pressure support of 5/5 or 5/6 or 8/5, 8/6, 10/6, whatever pressure support du jour that you have at your institution. This was done on T-piece. So essentially the most difficult way to do an SBT, which is T-piece, because the patient has to first breathe on their own, but also is not getting any support from the ventilator in the form of pressure support or PEEP to overcome the resistance of the tube. So if you are breathing well on a T-piece trial, not tachypnic, not tachycardic, whatever you deem is your way of figuring out if the patient is passing their SBT. Unfortunately, I think the RSBI score has been molded into this extubation readiness score, which Tobin took great offense to a few years ago when there was this sort of RCT, I think, or a meta-analysis to talk about the RSBI score, which there was sort of like this back and forth editorial commentary on chest, which you should really check out, and I'll try to link in the show notes at some point. But he made it very clear that that score was not for extubation success. It was for weaning readiness. That was the time that we would wean patients over days to weeks, and not we, because I was probably in high school at that point, but the critical care community at large would sort of wean patients over days to weeks. What we do now is we assess for extubation readiness with an SBT, so patients awake, alert, hopefully interactive, which is a whole separate sort of approach and discussion, but just imagine the patient's alert, awake, interactive, breathing on his or her own, so triggering every breath. So what we generally do is place patients on pressure support trial. Remember, pressure support is a spontaneous breathing mode. There is no backup rate. Most ventilators have sort of a fail-safe, so if the patient's not breathing on their own, it'll sort of kick in at some point after a certain amount of time, 20 seconds, 30 seconds, whatever you set. But every breath has to be triggered by the patient, which makes it spontaneous. The cycling is a little bit different, so how the ventilator goes from inspiration to expiration. With pressure support, you set a cycling threshold, meaning the vent will cycle from inspiration to expiration at a certain decay of flow. Because just like spontaneous breathing, as you get closer and closer to sort of full inspiration, the amount of flow you're taking goes down because that pressure starts to equalize. So once the pressure is equalized, no more flow is generated. So you can set this number. It's generally set to like 30%. So if you took in, 100 liters per minute of flow initially, your peak inspiratory flow, if it was 30% of that number, once it got to 30, then the vent would cycle off into expiration. There's some small studies to suggest that patients with COPD might do better with setting sort of a higher threshold, meaning like 50%. So if it was 100 liters per minute, when it got to 50 liters per minute instead of 30 liters per minute, you would cycle off into expiration. That would make your inspiratory time shorter. Why is that better for a patient with COPD? Remember, their compliance is very, very good, meaning it's very, very high. So any pressure differential is going to generate flow. So you could essentially trap a patient in inspiration with COPD on a spontaneous breathing trial, because as there's a delta in pressure, they're just going to get more and more and more and more and more flow, and they sort of can't stop it. They can't stop that delta because their compliance is so good. So what they do is get trapped in inspiration. They get super inflated. They get obstructed. They get closer to their total lung capacity, and then they start to auto peep and have ineffective triggers and all that kind of stuff. So cycling threshold is important. Now the other question is, what pressure support is appropriate? And there's been studies, and this isn't sort of like an over the top evidence-based pod. So, don't send me studies and say that, or please send me studies, of course, but I might sort of misspeak, but I think generally we can say that SBTs are sort of place dependent. Some places do 5/5, some places do 5/6, some places do 8/5, some places do 0/5. The key component to understand is that, and this graphic that I can also share that came out of a cardiac intensive care journal that was a few authors on it, but was titled Vent Liberation in the Cardiac Intensive Care Unit, which is essentially similar to the medical intensive care unit. That was authored by a couple different physicians, one of which is Willard Appelfeld, who was on the pod before, who's cardiac critical care, advanced heart failure, vent guru. Just the dude is unreal. So the way that they described it, which I think is brilliant, is on sort of like this slider system where T-piece is very, very specific. So as a screening tool, patients who might do well otherwise might fail T-piece, because if you give them that little bit of extra work of breathing to do, they're going to fail their SBT. A point of contention for Tobin was that he has some literature and did some studies to suggest that because of the breathing tube, when you take the breathing tube out, because of the swelling of the upper airway, your resistance goes up because the airway is narrowed just a bit. So he would say that sort of the most pure form of a spontaneous breathing trial is a T-piece. I think most of us don't do T-piece trials anymore. And if you do, I would love to hear it. You can sort of email me or comments or Instagram, whatever it is. But I think most of us do pressure support trials of some flavor. Now, if you have a patient on a spontaneous breathing trial of 12/5, let's say, right? That's a pretty good amount of pressure support. So while they might breathe spontaneously just fine on 12/5, if you drop that pressure support to 5/5 and they got very tachypnic and they fail their SBT, then you wouldn't extubate that patient. But does that take away from the fact that they did well with 12/5? I don't think it does. And I think that when we get very specific about the nomenclature, we sort of lose sight of the big picture. So the big picture is, can the patient breathe on their own? Are they awake enough to breathe on their own? Are they strong enough to trigger the ventilator? Are they interactive enough to sort of pass the checks and balances of, is this patient possibly ready for extubation? And then what is sort of your flavor for, or how much uncertainty can you stomach? So if the patient's doing well on 10/5, maybe they're a little tachypnic, but they're awake, alert, their vital signs are normal or normal-ish, and their disease process is getting better, do you give that patient a trial of extubation, or is 10/5 too high? So I think there's sort of two sides to that. Some would say 10/5 is way too much. I think, and I don't want to put words in Tobin's mouth, but I think Tobin would say that 10/5 is too much, because from the spontaneous breathing trial podcast that he did with critical care scenarios, any amount of pressure support he sort of thinks offloads the muscles of inspiration so much so that it decreases the work of breathing. And I think that's intuitive, that we understand that it does that. But the question is, how much is the being sort of intubated playing a part in why we think the patient is failing extubation? One of the ways that I demonstrate this to myself is if the patient's sort of tachypnic on 5/5 and the volumes are maybe mediocre, so some number, you can quote studies and say if the patient can take sort of a vital capacity breath of X, then they might pass extubation. You can sort of eyeball it, and if you have sort of a normal sized person and if they have an inspiratory capacity of like a liter, I mean, that's pretty good. But if they can only sort of muster at most 400 or 500 and they're breathing 35 times a minute, well, if you did the math on a RSBI, that might be okay. And remember, RSBI is not an extubation RSBI isn't an extubation success parameter. But at what rate of breathing is too sort of tachypnic for you? But is 35 and pulling total volumes of 400, which gives you a minute ventilation of around 12, which is like pretty good. Is that due to the tube, or Is the patient anxious? Are you just never going to get them to look pristine on 5/5? So do you roll the dice, pull the tube out, full well knowing they could fail and you might need to reintubate? Every hospital, I think, has different sort of levels of comfort that they are with reintubating patients. And I think most ICU leaders and leadership would say that we sort of expect to have this reintubation rate. Like, it shouldn't be zero. Now, it shouldn't be 50% because that's probably too high. I think what's quoted usually, and I don't know where the exact data point for this is, so maybe someone could sort of elucidate that, but we think maybe 15%, 15% should sort of be reintubated. If that, 15% sort of puts us in a realm of we're not being overly cautious, but we're also not being overly cavalier. As you go up on the number, so 15 versus like 50%, maybe that's overly cavalier. 15 versus 0% is maybe overly cautious. Suffice it to say that every day you leave the breathing tube in, you expose the patient to more risk, especially for ventilator-associated pneumonia, DVT, soft tissue injury, further sort of exposure to different medications, propofol, dexmedetomidine, other antipsychotics to keep them calm in bed because they're anxious, because they're on an SBT, even though they're breathing 35, they're sort of interacting appropriately, but we're not comfortable taking the tube out because they're not, passing all the very specific checks. So extubation and spontaneous breathing trials, I think, are sort of this very nuanced topic that we don't give a lot of credit to. It certainly falls on the practitioners to how comfortable they are with extubating patients that are high risk for reintubation. But as Tobin said on the podcast himself, most patients do just fine no matter what we do, which is sort of agnostic in a way because then it doesn't really matter. And am I just sort of wasting my time here? But I guess that could be a discussion for another day. If most patients probably will do okay no matter what we do, then does it really sort of matter? Is it 8 or 5 or 10? Is it really sort of the bedside clinical assessment that I'm not sure if we can sort of standardize and algorithmatize, I don't know if that's a word, but make it to this algorithm where they check all these boxes. Is the patient not agitated? Check. Are their vital signs normal? Check. Are they awake and alert? Check. Not everyone's going to be that. The neuro ICU has, multitude of patients that are not awake and alert, but they extubate patients just fine. There was that recent paper, I don't remember the journal, it might be intensive care medicine, about sort of extubating patients in the neurocritical care ICU, and nothing sort of correlated to extubation success except for presence of a cough, which I think is pretty good. And I think we could probably apply that to the medical intensive care unit. So, when I'm assessing a patient for extubation readiness, I am thinking personally of 3 different sort of global assessments. The first is, what is the patient's mental status? Because that's pretty important to breathing. If they're not awake and alert to some degree, then how can I pull the tube out confidently and know that they're going to protect their airway? Now, if it's a patient who maybe had a stroke or a seizure and they don't have, their mental status is like coming back and, we suction and they have a strong cough, they have a strong gag, even though I don't think gag is a great predictor of protecting one's airway. But nevertheless, it's always reported and it's always sort of comes into the discussion. But if the patient has a strong gag, strong cough, sort of strong muscularly otherwise, that's one thing that I look at. The second thing I look at is the vital signs. So as long as they're not overly tachypnic, what number is that? I'm not sure. The disease process does play a part. So patients with COPD and they're breathing 30 times a minute, I could almost be sure that they're going to be auto-peeping. And that is going to make everything worse. Increase the work of breathing, make them feel anxious, make them feel breathless. So remember, extubating patients with COPD is probably the most risky because you're going to have to pull the tube out pretty aggressively because they're definitely never going to look amazing. Because anytime you have a tube in their mouth and down their throat, it's going to make their resistance higher just by the nature of the tube itself. So I look at their sort of global neuro status, global vital sign status, for lack of a better term. So are they tachypnic? Are they tachycardic? Is the respiratory rate sort of appropriate? What's their blood pressure? Is if they're on the SBT and their blood pressure is like super high now, am I worried that they're going to flash and have sort of flash pulmonary edema from either, the preload sort of coming back because we're pulling the PEEP sort of away from them, that positive pressure in the chest. So do we need to diurese them? Do we need to get their blood pressure under control? Is their blood pressure very high because they feel like they can't breathe, so they're very anxious? Is their blood pressure very high because we didn't restart their home medications, which then if we pulled the tube out completely could sort of put them at risk for flashing after we pull the tube out? So these are all things that we look at, or I look at least. Certainly if they're hypotensive, that's also another discussion. So how much hypotension is okay? How much vasopressor is okay? Generally, the diaphragm eats up, quiet respiration sort of eats up a small amount of cardiac outputs, 5%-ish. I forget the exact number, but it's in the single digits, which makes sense because if you needed sort of like 50% of your cardiac output to satisfy your diaphragm, then we wouldn't have like evolved as humans in some way, right? So we can't sort of take a lot of energy breathing at rest because that wouldn't play into our evolution. That wouldn't play into evolutionary benefit. Now, when you're in shock globally, either you sort of can't deliver cardiac output, so that's a problem because you can't supply your muscles of respiration with energy to do the work, or you have sort of high cardiac output, like in sepsis or distributive shock, and maybe your diaphragm can sort of use that energy and that oxygen because the diaphragm is a slow twitch muscle, so it sort of like works for all the time using mostly oxygen as its energy source and can't do a lot of anaerobic activity. Because when the diaphragm starts to do anaerobic activity, we call that failing or tiring out. That's sort of like the global endpoint of tiring out is the diaphragm sort of switching over to anaerobic activity. Lactate goes up, get more acidosis, which begets more worker breathing, which begets higher PCO2, which then the patient gets altered, gets intubated. So one of the reasons we intubate people in shock is to offload the work of breathing. So instead of all this cardiac output going to the diaphragm to try to satisfy that muscle, we can redirect this cardiac output to other organs in the body. So we need to assess sort of the work of breathing on the ventilator. So getting back to the original point, which is SBTs, how I do it is neurostatus, very globally, vital signs, very globally, and then the ventilator screen sort of very globally. So what's the respiratory rate? What kind of total volumes are we pulling? Can I get them to do an inspiratory breath, like a big inspiratory breath? Are they not auto-peeping? These are questions that I have. And my general approach is if I'm getting 2 out of 3 that are good, so good vent screen, good vital signs, but sort of not so great mental status for whatever reason, I'm probably pulling the tube out. Great mental status, super strong, awake, alert, etc. Great vent screen, not great vital signs. Maybe they're tachycardic, maybe they're hypertensive. I'll treat them through that and then pull the tube out. Or pull the tube out and treat them, etc. And then lastly, great mental status, great vital signs, but the vent screen is just not doing it for me for whatever that reason is. If it's like tachypnea or low tidal volumes, I then make an assessment on what I think the patient's sort of respiratory mechanics are. If I think it's because of the tube and it's anxiety driven, I'll pull the tube out. If it's because of their disease status or disease state, the question becomes like, how much support do they need? If they need like 10/5 and everything else is great, but the vent's not, beautiful, but they just need a little bit more support, you need to make a decision at that point. Is it better to have the tube in and sort of, fix it, full well knowing that there's real consequences of that, meaning maybe sedation, maybe now they're further brewing a VAP and they get sort of ventilator-associated pneumonia in the next 24, 48 hours. Soft tissue injury, there's always something can always happen where the patient looks agitated, they get some the patient looks agitated, they get some Versed or something, and now they're delirious. Who knows? We know that the number one cause of delirium is being intubated. So there's nothing to say that despite our best effort, if we leave the patient intubated one more night, that they're going to get delirious sort of overnight or that day, and now we have a whole other system to worry about. And we know that delirium sort of increases odds for everything else going wrong. Increased ventilator length of stay, mortality, morbidity, hospital length of stay, etc. So there's a real question when you have someone who's sort of borderline, who's getting better, if you should pull the tube out or not. And I'm not sure if our current approach to spontaneous breathing trials really gets into the weeds or underscores the nuance of spontaneous breathing trials, what constitutes one, and when we should be aggressive and when we should leave a patient intubated knowing what the risks are. So this has been sort of a long-ish rambling SBT kind of post. I would love to hear everyone's thoughts on how you guys do SBTs in your different sort of places, knowing that there's no sort of perfect way to do it. Everyone has a different way of doing it. I don't know if the literature supports like a specific way of doing it. It's not something that I think You could be more invasive, certainly, with your SBTs, like dropping an esophageal balloon and trying to interpret sort of worker breathing. And there's certain sort of joules per minute of worker breathing where if you go above that, then that's a higher rate of failure. So you can get like very technical with the SBTs, different vent modes. So using NAVA or using PAV if you have Puritan Bennett's, and NAVA if you have McKay servos, to sort of understand how much help the patient needs breathing. So how much extra work, because at the end of the day, someone has to do the work of breathing based on the resistance and the compliance of the pulmonary physiology. If you think the patient can do that work, then you should take the tube out. If you don't think the patient can do the work, then you should either leave the tube in and or extubate the patient to some form of support if you think that that underlying pathophysiology is going to get better in the next day or so. The question becomes, how aggressive and what's your appetite for extubation failure and ultimately needing to reintubate the patient, which again, I don't think is sort of a dirty term. I think this is what happens in the ICU. Patients are sick. We extubate patients. They get reintubated sometimes. And not to sort of downplay the severity of it, but that's, part of what we do in the medical ICU. So let me know your thoughts. Let me know if this is actually more or less helpful than maybe more prepared stuff as far as the podcast goes, and talk to you soon. Thanks.